Whatever may be the source you followed for dermatology, this video is going to help you to revise quickly the cutaneous tuberculosis. Watch this video till the end. Dear students, hello, myself Dr. Maddineni Srinivas. Welcome back to my channel. So if you're not yet subscribed, please do subscribe and also like this video if you like this concept of very quick revision videos related to dermatology. So let us begin the discussion without any further delay. So the topic is cutaneous tuberculosis. So here remember the immunity of the patient and also the mode of acquisition are going to decide on the classification of the cutaneous tuberculosis, which could be exogenous, endogenous, or could be hypersensitivity reaction. So in the exogenous, remember we have this tuberculous chancre, which is a primary form of cutaneous tuberculosis. And the patients are TB naive and they are going to have multiple bacillus inside the lesions, and the ulcers are going to be undermined edges and they are going to be painless. So in dermatology, where else can you see the undermined edges? I will give you a clue. It's a neutrophilic dermatosis. If you remember the name of the disease, put your answer in the comment section. And also there is one more STD in which we are going to see the undermined edges. If you know the answer, put it in the comment section. We will see the answer at the end. So another condition exogenously acquired is post-primary form, which is the TBVC, Tuberculosis Verrucosa Cutis, in which it's also called as anatomist or pathologist. What? Because in these the specimens or the cadavers which they were handling, they were having the MTB bacillus which are getting inoculated, leading to the development of the warty or cauliflower like growths. And because these patients are having a good immunity, they are going to have few bacillus in these patients in the lesions. Next we have this endogenous variety, which is the lupus vulgaris, most common form of the cutaneous tuberculosis in adults in India. It's going to present as a annular lesion which has a central scarring, and the peripheral is going to show the extension, and the lesions are going to be very dry and they are going to be very few bacillus. So it's a paucibacillary type of cutaneous tuberculosis. Coming to the other endogenous, it is scrofloderma. It is the most common type of TB in the children in India, and it is multibacillary variety where the most common focus could be lymph node, bones or joints, but the most common is cervical group of lymph nodes. And you should remember that it's going to initially produce a subcutaneous nodule over the skin, ultimately discharging signs as ulcers are going to form, which are going to heal with a very bad scar formation. Next is periorificial tuberculosis. So surrounding the orifices or the body, they are going to be the ulcer formation, and obviously it's going to be multibacillary in state. Next is the hypersensitivity reaction tuberculates. Here remember the patient's immunity is very good, so if you do a man-to test, it's going to be strongly positive, and the bacilli are going to be very difficult to demonstrate because the lesions are because of hypersensitivity reaction against the MTB bacillus. So what are the important diseases which you need to remember? They are the lichen scrofulosaurum, papillonecrotic tuberculate, and Berzon's disease. So lichen scrofulosaurum, micropapillary lesions will be seen over the trunk. Papillonecrotic tuberculate, necrotic papules will be present, especially over the extremities. Berzon's disease, remember, it's a type of panniculitis. What is panniculus? If you remember, put it in the comment section below. Answer at the end. So posterior aspect of the leg is going to show erythematous tender nodules in the case of Berzon's disease. There is one more condition which is going to present with erythematous tender nodules over the body, against erythema nodosum. So how to differentiate? In erythema nodosum, the lesions are going to be present over the shin, that is anterior aspect of the leg. And this is lobular panniculitis, whereas erythema nodosum, it's a septal panniculitis. And erythematous tender nodules are going to ulcerate and they are going to heal with scarring. In Berzon's disease, where they are in the erythema nodosum, there are going to be no ulcers, there is no scarring in the erythema nodosum. So very important points to remember the differences between these two conditions. Coming to the atypical mycobacterial infection. So remember swimming pool granuloma or fish tank granuloma, which is produced by the Mycobacter marinum. It is usually seen in the swimmers or those who handle the fish handlers, right? And the clinical presentation is going to be in the form of nodular lymphangitis, where the spread is going to be in a linear fashion, which is also described as a sporotrichoid pattern. So what is that fungal infection which you are going to say the sporotrichoid pattern? If you know the answer, put it in the comment section. Yes, the answer is sporotrichosis because of Sporotrichia chancre, which is a dimorphic fungus, right? And it is going to show asteroid bodies on histopathology. Now coming back to this, the treatment we are going to use, drug of choice is minocycline for the Mycobacter marinum infection. We could also use azithromycin also. Next is Buruli ulcer, which is produced by the Mycobacterium ulcerans. Here the toxin mycolactone is going to destroy the tissues, because of which ulcer is going to be produced, which is painless ulcer having the undermined edges. Again, undermined edges ulcer, again common for Mycobacterium. Treatment is combination with rifampin in streptomycin. Coming to the investigations, how can we diagnose this cutaneous tuberculosis? So we have this diascope, which is also called as vitropression, in which we are going to press the skin lesion with a glass slide, where we are going to see this very important apple jelly nodules as yellow brown color, which is very characteristic of lupus vulgaris. This can also be seen in other skin conditions. Do you remember what are those skin conditions? Put your answer in the comment section below. So they are sarcoidosis and cutaneous leishmaniasis. So I have told you the answer here itself. And what is the investigation of choice for diagnosing cutaneous tuberculosis? Obviously, it's going to be the biopsy of the skin, where we are going to see the tubercular granulomas along with the Langerhans giant cells in the dermis. Remember, Langerhans giant cells are different from Langerhans cells, which are the non-keratinocytic cells which are present in the epidermis, especially in the stratum spinosum layer, and they are the antigen presenting cells. So whenever you read dermatology or any subject, at the end before the examination, when you are revising, always try to integrate all the topics in the subject, and also try to integrate in between the subjects also, so that you are going to remember the topics very long enough. Right, coming back to the topic again. So PCR, polymerase chain reaction, it is the most reliable confirmatory test for the paucibacillary forms of the cutaneous tuberculosis. That is, whatever cutaneous tuberculosis is going to be presenting with dry skin lesions, all of them are paucibacillary, that is lupus vulgaris and also the TBVC, both of which were presenting very dry and rough surfaced skin. So basically this is going to detect the DNA of the MTB bacillus, because of which it's going to offer a high specificity of the diagnosis. Next is chest X-ray, can be used for screening, as 10 to 20% may have the concurrent pulmonary tuberculosis also. Coming to the treatment of the cutaneous tuberculosis, remember the ATT is going to be the same, which is going to be given for pulmonary tuberculosis, GI tuberculosis, and also this cutaneous tuberculosis. I hope this video was helpful. So please do the like button, also do subscribe for more such videos on a regular basis. We'll meet in the next video, but before that, what are the answers? So undermined edges ulcers are going to be the pyoderma gangrenosum and also the chancroid, which is a sexual transmitted disorder. Can you remember the name of the organism producing the chancroid? If you have answered it as Haemophilus ducrei, you are absolutely right. What is the treatment we are going to use for Haemophilus ducrei chancroid? Yes, it is azithromycin, which is a macrolide antibiotic. So thank you so much. If you have any doubts, put in the comment section. Bye bye, happy learning. We'll meet you soon.